We will now proceed for the final session of the day, circulatory support. The chairpersons for this session are Dr. Kunal Sarkar, Dr. David Rosario, Dr. Ashok Malpani, Dr. Sanjeev Mukherjee, and Dr. Arindam Pandey. This session will be moderated by Dr. Dilip Kumar, and the expert panelists for the sessions are Dr. Indra Kuladipati, Dr. Bimlendu Kumar, Dr. Ashraful Haq. I request the chairperson and the moderator to take over the proceedings, sir. Thank you.
Thanks, Dr. Saurav. And we have moved to the final session of the day. And it's on a very interesting and important topic, that is circulatory devices. So at the outset, let me extend my apologies to Dr. Tarun Chakravarti for spelling mistake in the invite. So with advancements in technology, hardware, skill, and the knowledge, we are moving towards salvaging the non-salvageables, and where the circulatory devices are coming into picture. So we have Dr. Tarun Chakravarti. He is a senior cardiologist from Cedar Sinai Medical Center. I invite him to start his presentation.
Thank you so much. Let me share my screen so you can. Okay, can you see my screen and can you hear me?
Yeah, we can hear you loud and clear, and we can see your screen.
Okay, great, thank you. Thank you for this kind invitation. It's a pleasure and a privilege to to give this talk, and I'm very appreciative. So I'm going to talk about impeller hemodynamic support for protected PCI. I have no conflicts of interest. So, the data supporting protected PCI indication for impeller comes from several studies, ranging from Protect 1, which was a small prospective study of 20 patients, Protect 2, which was a randomized controlled trial, Protect 3, which is a post-US approval registry, and then there is a US impeller registry and literature review. And now we have the CVAD registry in the United States, which takes into account all patients who undergo impeller guided procedures in the hospitals. So Protect 2 study, this was a randomized controlled trial that took patients with left main disease and EF less than 35 or triple vessel disease with EF less than 30. And they were randomized to PCI with balloon pump or PCI with impeller 2.5, which was the earlier impeller device. And the primary endpoint was 30-day and 90-day composite major adverse events, which was a heterogeneous cohort of death, MI, stroke, TIA, repeat revasc, vascular operation, limb ischemia, acute renal dysfunction, a very heterogeneous endpoint. So, and the primary outcome of this study was the conclusion was a 30-day incidence of major adverse events was not different for patients with balloon pump or impeller device. However, there were trends towards improvement in outcomes. And that's what I'm going to focus on. If you look at the procedural performance, because you have more hemodynamic support with impeller, it gives you more confidence and support. So the proportion of patients who underwent rotational atherectomy was significantly more. Discharge from cath lab on device was significantly less in the impeller arm, and the total time support time for hemodynamic support was also less with the impeller device. The major adverse events, there was a reduction. Still, there was a 22% reduction, but it was not statistically significant. But when you look at the hypotensive events, which is the biggest concern when you do these high-risk PCIs, the number of hypotensive events was significantly less in patients who got impeller versus those who got the balloon pump. Also, the more patients underwent complete revascularization in the impeller arm compared to the balloon pump arm, because it gives the operators more confidence, more support, more hemodynamic support to continue with the complete revascularization. Also, a significant reduction in the incidence of major adverse cardiovascular and cerebrovascular events. This includes death, stroke, MI, and repeat revascularization, which are the standard endpoints for all cardiology clinical trials. And there was actually a significant reduction in this endpoint at 90 days in this trial. There was also an improvement in quality of life with 59% reduction in NYHA class 3 or 4 heart failure. The length of stay was less in the Impella cohort compared with the balloon pump cohort. And also the Impella patients who underwent revasc high risk PCI, protected PCI with Impella, they had fewer readmissions for a repeat reintervention because they underwent a more complete revasc at the index procedure. This was an interesting finding. Even I wasn't a believer until but now we see it. There was a significantly less risk of AKI, acute kidney injury during high risk PCI with the use of Impella unloading. Which was an interesting finding, and it's been a consistent finding in multiple studies from multiple medical centers. There's an improvement in LVEF in patients who undergo this PCI. It's not a surprise, post revasc you expect EF to improve. So based on these data, the FDA approved Impella device for high risk PCI. And high risk PCI was defined as complex coronary anatomy or depressed LV ejection fraction, with concern for hemodynamic instability during PCI. Now, in the United States, there has been a significant increase in patients who are receiving mechanical circulatory support. And mechanical circulatory support could be Impella, it could be a balloon pump, it could be ECMO or LVAD. But there has been a significant increase in patients who are undergoing PCI with mechanical circulatory support in the United States. And this also reflects most type A lesions are being managed medically. So the high risk PCI, since a lot of these PCIs are high risk PCIs, so we are using more hemodynamic support. Here's a multi-center Italian registry of 406 patients from 17 centers. And the Impella for high-risk PCI in this study was used in 44% of patients. So that's pretty remarkable. Now, Protect 3 study, it's a non-randomized prospective it's a FDA post-approval study for Impella supported high-risk PCI. And so the outcomes are, not all the outcomes are still available, but here's a snapshot of outcomes that were recently presented that looked at major adverse cardiovascular and cerebrovascular events, so death, MI, stroke, and repeat revasc. And in the Protect study arm, there is a significant reduction in these events compared with the control arm from Protect 2 trial. So it's a bit of an extrapolation of data, but at least the results are consistent with the trial, if not better. Now, the two indications for Impella, and I'm focusing on protected PCI, but the two indications are protected PCI or cardiogenic shock. And it's almost a 50-50 distribution. Here's a post-approval surveillance study that shows that 45% of Impella usage in the United States is for high-risk PCI. And even in the Protect 3 study, there we have noted a significant reduction in acute kidney injury in patients who undergo PCI with the Impella device. So I think it's more fun to review cases. So I would spend the last 3 minutes reviewing a few cases. So here's a patient, 95-year-old patient who presented with heart failure. He had 80% distal left main bifurcation, 99% mid RCA, and he's 95 years old. There is no surgical bailout. And his EF was 20%. So EF is significantly depressed, not a candidate for any advanced therapies. So we brought him to the cath lab and we put in an Impella, which is kind of ridiculous in a 95-year-old, but we did it. He was a functional 95-year-old. And we put in the Impella and then we did DK crush stenting and took care of it. And Impella was removed at the end of the procedure. Now here's an elective left main PCI with Impella. This is a patient that I recently treated, 68-year-old male. He was initially referred to me for TAVI. His EF was 20%, he had critical aortic stenosis, and he had severe left main disease. So we first brought him to the cath lab and we did a TAVI. And believe it or not, we left this left main alone. We just put a wire down the left main to protect it. We were ready to intervene if patient has hemodynamic compromise, but our preference was to leave this alone and manage medically and bring him back later in a staged manner for PCI. So we fixed his left main. His EF continued to be 20%, and then we brought him back a couple of months later. We put in an impeller electively through the transcatheter valve, and we went ahead and we fixed it with two drug-eluting stents with the DK crush strategy with a good result. Okay, now here's a patient who had left main PCI. He had a normal EF, but he had moderate AS and moderate MR. So there wasn't much physiologic reserve. So 91-year-old presented with worsening chest pain. He underwent coronary angiogram and terrible, very ugly left main disease, very ugly left main into the LED. It's holding by a thin thread. So we brought him to the lab. His EF was normal, but because he had moderate MR and moderate AS, borderline aortic valve area, there's very little physiologic reserve. Plus, patient had focal stenosis in the left common iliac artery. So we actually dilated the tract with the impeller sheath, and then we put in the impeller device. And then we went ahead and we wired the lesions and we stented these. We went with the DK crush stenting again, and we got a beautiful result. Impeller was removed at the end of the procedure, and this patient was discharged, I think, 2 days later. Now, this is how it works. You will see when you have impeller device, your arterial pressure, it flat lines because there is no output, but still impeller device support continues. And that's how it gives you confidence to treat these lesions. Here's a study that shows improved aortic pressure and decreased LV-EDP in patients who get impeller device. And also there is increased perfusion pressure in patients who have an impeller device, similar to balloon pumps. Now, bailout impeller. This is, this is same as rota regret. If you think about it, you should use it. This is a 90-year-old retired physician with severe AS, EF of 20%, who presented with NSTEMI. We brought him to the cath lab, and we took an angiogram. We were ready to do TAVI in this patient because he had critical AS, and we thought about it, but we didn't put in a hemodynamic support. We inflated a balloon, and then he had slow flow and he arrested. So we did emergent TAVI. We deployed the valve while he was actively coding. And then we went ahead, we finished the job, and we put a subclavian impeller, and he was transferred to the ICU, and he was discharged on post-op day 11. He was one of the lucky survivors, but bailout impeller is always a regret in the end. Here's a study from Bill O'Neill from Detroit that shows that patients who undergo PCI with bailout impeller, when they crash, they have significantly worse mortality compared to patients who undergo PCI with elective impeller. Now, there are patients who are just not candidates for impeller. Here's a patient who was, he's still in the hospital here actually. He's a 49-year-old male. He was transferred for higher level of care. His EF was 20%. He had critical RCA, heavily calcified RCA. He had critical LED, diffusely disease extending from ostial left main to the LED. His EF was 20%. His RV was severely depressed. He's a dialysis patient. A1C is 11, very frail, despite his young age of 49. He was turned down by 3 surgeons, plus he had an LV apical thrombus, so we couldn't even put an impeller. So in this case, we put him on ECMO in the cath lab. We did percutaneous pre-closure of the groins with perclose. We put him on ECMO. We rotablated the RCA and then stented it with 3 stents. And then we went ahead, rotablated left main to LED in the same setting. And we put a few stents in the LED, from left main to the LED. We left the circle alone. And we removed ECMO 3 days later, and he's still in the hospital recovering, but he's out of the ICU and ready to go home soon. So I will conclude here with hemodynamic support with impeller for high-risk PCI. It results in hemodynamic stability with fewer hypotensive episodes, facilitates more complete and more optimized revascularization, fewer major adverse cardiac events during follow-up, decreased risk of acute kidney injury, and most important is if you think about it, then you use it. So hemodynamic support with upfront impeller usage electively instead of bailout impeller should be the preferred approach in most high-risk PCIs. Otherwise, we'll have an impeller regret in the end. Thank you.
Thank you, Dr. Chakravarti. It was a brilliant talk. And Dr. Sanjog Kalra has a question for you.
Yeah.
Dr. Kalra, yeah, please. Dr. Kalra?
Sorry, I had some trouble turning on my microphone. Thanks very much for your talk about high-risk PCI. My question is about device weaning and removal at the end of your cases. I think those of us who are here in North America have a fair amount of experience with the device, and now we're starting to realize that there's putting the device in and doing the case is fairly straightforward. It's when do you take this thing out and how long are you going to deal with the bleeding events, the axillary thrombosis, laminar flow issues, et cetera, that come up. And I struggle with this, as do all of my friends and colleagues who are doing these cases regularly. What are your targets, procedures, protocols for device explant at the end of the case versus keeping it in the ICU? And to guide you.
Okay. So, it's a great question. And, I don't think any of us know the right answer. But our approach, I think Impella, it has its benefits during high-risk PCI. After high-risk PCI, when you're done, it can also cause a lot of harm. So, our preference has been to take Impella out in the cath lab at the end of the procedure if patients tolerate. So we do a gradual wean. We monitor the EDP. We monitor the hemodynamics, and if the hemodynamics are stable, I would say for elective high-risk PCIs requiring Impella support, I would say we take them out 9 out of 10 times in the cath lab. But patients who are in shock, who come in for bailout TAVI, for bailout PCIs with support, those patients, Impella catheters stay in longer. I've had 2 patients who developed really bad lower limb ischemia, and to the point they had to go for fasciotomy and amputation and stuff. So now 100% of the Impellas, if they leave the cath lab, they go with a perfusion cannula to the lower extremity, so that the concern for limb ischemia is minimized.
Great. So, our
For
chairperson.
you, Torun, after your brilliant talk, Dr. Kahali here, excellent case presentation, fantastic. Now you are doing lots of Impella throughout USA, but in India, we cannot do because of the financial factor. Is there any randomized data, I don't know about it, in comparison to IABP to prove the superiority of Impella?
So, the PROTECT 2 trial was took patients with left main disease and EF less than 35 or 3-vessel disease with EF less than 30. They were randomized to either Impella guided PCI or balloon pump guided PCI. The trial did not meet the primary endpoint, which was a
So it was a
heterogeneous.
randomized trial?
Yes, it was a randomized study. Now, there is another trial called PROTECT 4, which is ongoing in the United States, which is a much bigger study. And that trial is again randomizing patients with high-risk coronary anatomy requiring high-risk PCI to balloon pump guided PCI versus Impella guided PCI. But the endpoint here is not heterogeneous. The endpoint here is major adverse cardiac and cerebrovascular events. So the trial is ongoing. We are participating in the trial at our site also. And I think the results should be available in a couple years. But for now, PROTECT 2 is the only randomized trial that didn't show an impact on the primary endpoint. But if you look at the impact on death, MI, stroke, or repeat revasc, it was less. Acute kidney injury was less. Repeat hospitalizations were less. And there was more complete revascularization.
Do you think that this will be translated to Impella CP also from your personal experience, because you are doing a lot of cases there? Because previously, I believe you have been using 2.5 Impella and now you are using Impella CP. So do you find any change after doing this one? One is better than the other?
Oh, absolutely. I think Impella CP gives you so much support. And there are cases, I didn't show those cases. If the LV is really bad, if left main into the LED is the last remaining conduit, we've even done these cases with subclavian Impella, which is Impella 5.0, which gives even more support. But I would say for most of our we don't use Impella 2.5 anymore. So our default device is Impella CP, and it gives us a lot more support. We get flow of around 3.5 liters with Impella CP, which is very adequate.
Yeah, because I think Impella, this PROTECT 2 was with Impella 2.5 and the newer ones is with 3.5. CP, sorry, Impella CP.
Yeah.
And what is the gross indication? We know that it's a LV dysfunction, left main critical PCI cheap cases. As you have shown, beautiful calcified lesions I was seeing, amazing RCA, and you work very comfortably because there is no, tension on the operator. And so is there any increase in the improvement in the mortality data from your personal experience? No randomized data because you told it's ongoing trial.
I think,
So
hemodynamic support, it's one of those things. The only way to find out is to not to use it. And but I don't think any of the cases that I just showed, I don't think we would be able to do these cases without
yeah,
Impella or
impella, yeah,
ECMO or tandem
yeah,
heart.
yeah,
So I think it's one of those things. Jumping without a parachute, will never find out because we would never do these cases without support.
yeah.
Um, and Protect 4 trial is randomizing such patients to PCI with balloon pump versus Impella. But I'm the site PI for our center for Protect 4, and I doubt that I would enroll such patients in the Protect 4 trial because I don't think I would be comfortable fixing these lesions with a balloon pump.
Arindam, do you have any question? Dr. Pandey? So before
So anyhow, Tarun,
Hi, Tarun.
fascinating
How are you?
cases you have shown. Yeah.
So, seeing you after long. So,
yeah,
I have a very simple question. In our country, Impella is very, very expensive. So, if Impella is very, very expensive, many times we cannot of ECMO in our center, which is
Arindam,
widely
I'm sorry,
available.
your
Data
voice is
with folks
breaking.
using ECMO.
Arindam, your voice is breaking. I can
Yeah,
hardly hear you.
yeah. I think audio team kindly, Raghu, kindly see to it, please.
VA
Raghu,
ECMO
kindly
versus
see.
Impella.
Yeah.
So I think it's a great question, and the cases, keeping cost aside, because for us, fortunately, in the US, cost is not an issue. So keeping cost aside, for us, if RV is bad, then Impella alone may not offer a lot of support. You know, so because Impella only gives you left-sided support, and for bad RV, it can actually lead to worsening RV failure. So if RV is bad, then we consider using ECMO rather than Impella for hemodynamic support. Or if there is a left ventricular thrombus, or if um, access is an issue, but access is an issue for VA ECMO also. But those are the primary two such scenarios. If RV is bad and the coronary disease burden is very extensive, or if there is left ventricular thrombus, so we cannot put in an Impella device, then we use ECMO. Or if there is a lot of aortic regurg, then we cannot put an Impella, then we have to go with ECMO.
yeah, I have a question to ask. Why have we not got any positive results in cardiogenic shock patients? Is it the late deployment of Impella? Do you feel that early deployment can get us a better result, a significantly better result?
I think so. I think once the shock cascade begins, it's very hard to reverse it. And treating cardiogenic shock should be like treating STEMI. The sooner you get in with support, the better the prognosis. So I think one of the reasons is, that we get to it too late. But I think also the other reason, shock is a very complex, heterogeneous cohort. And I think the real value of Impella would be in cardiogenic shock related to acute MI, and that's where the Impella unload trial will come in very handy. That's also enrolling in the US right now, where patients who come in with an LED STEMI, they are randomized. So you first put an Impella in patients who are randomized to the Impella device. They will first get an Impella. They will undergo unloading for 30 minutes with no intervention. And after 30 minutes, they will undergo PCI, and the control group will undergo routine PCI as usual. So I think it'll give us some insight.
Dr. Sanjog Kalra also writes the same. He says he has got survival of 77% or 50%, provided we deploy it earlier before the
Yeah.
cardiac shock cascade sets in. So in the interest of time, we will move on with the last presentation of the day. And I am really happy and pleased to introduce Dr. Arpan Chakravarti. He is head of the department cardiac anesthesia at our hospital, Medical Specialty Hospital, and I take pride. We are really proud of him. He heads the department which does which has the distinction of doing maximum number of ECMOs in Southeastern Asia. So, Dr. Chakravarti, all yours.
Sharing my screen.
Please go on.
Is it visible?
Yeah, we can see slides. On the slide share now. Yeah.
So the actual debate started actually by Dr. Tarun Chakravarti that what should be our next decade phase. It is DOT to ECMO or DOT to balloon first. So that's the thing we are starting. And obviously, I don't have any financial interest. And I've tried to accommodate the pictures, videos taken by me or my colleagues in our ICU in Medica. And I've taken permission from the patients before showing their pictures. And we have started our ECMO program in a small with one machine in 2014. And obviously, the name of the ECMO has came from the oxygenation to life support to the organ support. So names are changing. And we know there is a component of VV and venoarterial, both we have. And indications are obviously the refractory cardiogenic shock, which comes the first. Few things like ECPR, massive pulmonary embolism, pulmonary hypertension, and the most important is the peri-procedural support during the high-risk cardiac intervention, which has been tackled, Dr. Chakravarti, in a very way. So obviously, the red one comes with the first that before putting the patients on ECMO, it has to be a likelihood of organ recovery, which is the most our priority. And we should avoid multi-organ dysfunction. And before the starting of this multi-organ dysfunction, here is a shock, which is the main thing. It's a heterogeneous cohort, which is causing a lot of problems. And people told they lactate more than 10, don't put them on ECMO, they don't do well. So it's not always easy to get patients when the patients are not on severe cardiogenic shock, and you are counseling the relatives whom to put on ECMO or not to put on ECMO. This takes time. So gradually this time is getting shorter with the advent of the knowledge and the awareness. So when we put them on ECMO, what we adopt an optimal cannulation strategy. Cannulation of ECMO is the admit card for an ECMO. It is a short procedure, but if you do a good cannulation, the ECMO will run very well. So we call it cannulation as an admit card to the ECMO exam. And we follow this urgency of the situation. What are the underlying cardiac issues? We have a biventricular, what we are thinking, where we are discussing previously, we have a biventricular heart failure or not. What is the pulmonary status, the size of the arterial vessels, need for further mobilization, anticipated duration of support, and the size of the cannulas, which ensure the adequate flows. And it's a central or the peripheral cannulation. And the cannulation techniques obviously comes with the open, semi-open, and percutaneous. And most of us, we do is the percutaneous, which is out of the operation theater scenarios. It is a percutaneous which goes very well. And sometimes we do semi-open when we are not getting a good pulse, or it's a ECPR thing. The semi-open actually prevails for that. So we have some different scenarios for different type of cannulations for an ECMO. Like a patient who suffered a perioperative myocardial infarction in the left main disease, unable to come off CPV, or a massive pulmonary embolism with recurrent cardiac arrest. It's a failed thrombolysis. It's a post-cardiac arrest sequelae with extensive peripheral vascular disease and a stuck mitral valve presented in the emergency with a very low cardiac output. These four scenarios have four cannulation strategies. Like it's in the operation theater, which is perioperative MI, not able to come off CPV in the left main disease. You put central typical aortic and this right atrial cannulations with the pulmonary arterial vein, or a massive pulmonary embolism with recurrent cardiac arrest. You have started thrombolysis, but it failed. So you put a femoral venoarterial cannulation with the distal perfusion cannula, which is exactly opposite to the this your arterial cannula. Or a post-cardiac arrest sequelae with extensive peripheral vascular disease. You don't have access to your femoral arteries. So what you do, you got an access for a right axillary artery, either by opening method or a Parker technique. And this is another case where the stuck mitral valve, which is again came with a cardiogenic shock. We rescued the patient on putting the patient on peripheral ECMO. We just put a venoarterial cannulation, like it's a percutaneous arterial cannula which is going towards the heart, and this is the distal perfusion catheter which is exactly opposite to the thing. And this is how the patient goes. We rescued the patient on ECMO and operate after that. So, and obviously after doing the proper cannulation, do check the cannula position, sometimes by transesophageal echocardiography, sometimes by transthoracic, or sometimes by by imaging. And obviously there should be no bleeding or cannula site or bleeding injury, because if the continuous bleeding happens, you cannot give a good flow, and the purpose of your ECMO is not going to solve it. And obviously you have to, after what you do after the putting on ECMO, it has to be adequacy of the tissue perfusion. Mostly we follow the lactate and the urine output, that the poor man's cardiac output and the poor man's this ECMO management, which goes for the urine output and the lactate, and we anticoagulate till and target ACT of 180 to 200, and later on we measure, we maintain that APTT 1.5 to 2 times. And obviously we have, because femoral veno-arterial ECMO is a retrograde flow, so brain is the distal most the organ from your cannula tip, so you have to keep in touch, keep in very cautious that your cerebral circulation is adequate and not always remain a question. So you put always a this NIRS or a near infrared spectroscopy. If the patient is awake, it's fine. Otherwise, you have to measure all this, because you're in femoral veno-arterial ECMO, which is a peripheral ECMO, most commonly used ECMO in the cath lab and then the cardiology setup, where the brain is the distal most portion of your distal most organ from your ECMO flow. And what are the subsequent difficulties we face on ECMO in this kind of patient? Obviously, the limb ischemia, followed by this LV dilatation and the pulmonary edema, cardiac tamponade can happen, which goes for a loss of pulsatility of your arterial waveform, and the upper body hypoxia when the patient is improving, the patient's lung is going down. How we put the distal perfusion cannula? Just 2 punctures in the groin. One is towards the heart, one is towards your the same leg, will give you the good distal perfusion. And you cannulate by the serial dilatation technique with that the same sheath which is going towards the heart, and put the distal, put your cannula, the main cannula, this perfusing cannula with that, and you just take that output from that cannula and to supply your distal perfusion. And sometimes in hurry, in ECPR situation, we don't get this retrograde cannula to put and waste our time. So then we put the distal perfusion cannula in the posterior tibial artery by just small cut down, and perfuse the same limb with this the small posterior tibial artery with the 5 French or 6 French catheter. Obviously, the limb monitoring goes the most important. Consider it, measure, report the bilateral diameter. It is before it is getting too tight and the fasciotomy needed. And if you see the checking the distal perfusion is always an important issue. After putting the patients on this ECMO, we do check our the flows in the distal periphery, because this limb where we put the cannula and we are checking the popliteals, how they are perfusing, you will not get a very good pulsatile flow, but you will get a mean flow, and this will give you a good idea of how much distal perfusion is going on through this small distal perfusion catheter. So this we keep on checking on your the limb where we put the peripheral veno-arterial ECMO. And sometimes checking the flow in the distal limb, if you have a small gap in between your cannula and the artery, you can get a pulsatile flow. And if you have these IAB pins in the opposite limb, you can get some amount of pulsatility in your flow. So obviously, you have to optimize flow during your ECMO, because this flow is going to supply your cardiac output to the body, and you have to optimize the mean arterial pressure, which is in between 60 to 80. Some says it should be less than 50 to 60, just to keep the perfusion to the vital organs, and always exclude that some vasodilatory effects, hypovolemia due to bleeding, distributic shock, or post-cardiotomy vasoplasia. And in ECMO patients, if the MAP is going down, we achieve by increasing the veno-arterial ECMO flows or increasing the SVR with the vasopressors. Arterial trace, there should be some amount of pulsatility, because if the arterial trace is a bit pulsatile, it will show some LV is pushing some blood antegradally. So target pulse pressure is more than 20, but sometimes it is not. And echocardiography, you have to continuously check on ECMO. This aortic valve is opening. How is it opening or not? LV, is there any LV and aortic clot is found? LV is getting distended, or there is a mitral regurgitation is happening. And obviously, if you lost the pulsatility, it is because of your poor myocardial function, which is going to be poor for another 2-3 days. Excessive VECMO support, because it's a retrograde thing, retrograde flow, which is going to give the pressure on your heart. Inadequate preload, you need to give a fluid, or you have a RV failure. And management is obviously sometimes you need to give some inotropes for your RV support, unload the LV with the vasodilators, IBP and Impella, LV or eleventing or decreasing the VECMO flow. Target pulse pressure should be more than 20 on your total ECMO run. And if you see, this is our experience where this progressive LV distension, when the patients are put on ECMO and this IBP screen, it shows this kind of thing. There is a progressive LV distension, and you can see that in every beat, the aortic valve is not opening. So LV is getting progressively distended with no aortic valve opening almost. So this is the grave picture where you're, because of your, you should be dreadful of that. This LV is getting distended. And obviously, if you see the echo, you will say get this kind of distended LV on that, on ECMO, and a lot of contrast inside. And another thing where the loss of pulsatility can happen even when otherwise uneventful ECMO run, where you will get some amount of pericardial tamponade, and you have lost the pulsatility. So you have to exclude this tamponade also before asking for why the pulsatility has been lost. And LV overload, LV distension is almost incidence is 12 to 68%, and it causes subendocardial ischemia. It can cause pulmonary edema. You can see the froth coming out of your endotracheal tube, even after putting him on ECMO. It causes annular dilatation, and that causes LV and aortic stasis. This kind of pictures, X-rays, you can find next day where we put the patients on veno-arterial ECMO with the pure LV distension, pulmonary edema, and this kind of heart, which is the LV is distended. And this is the most dreadful one, this LV and aortic valve thrombus, which is seen in the penultimate, the ultimate thing, which is there's a big thrombus which is inside the LV on patients on ECMO, and because of the LV stasis is going on. Here comes the role of other venting options, where you should avail it before going to this. Look at this, on every beat, the aortic valve is not opening. So this is the thing we have to check it after putting on patient on VECMO. So obviously, how do we manage this LV distension on veno-arterial ECMO? It is by, obviously, it is by putting IBP. It causes some amount of this LV unloading. You can create a this PFO by this means. If a larger PFO, it can release some kind of LV distension. We have done transeptal LA venting, and there is one case we have done also Mullen sheath, which through femoral vein, and through it with transeptal LA vent we have put and taken out that this LA blood to our circuit and manage the LV distension. And sometimes in babies, what we do is we put a LV vent through this transapical incision, and put a direct LV vent for the babies with the VECMO, the transapical epi vent. This was a baby with 11-month-old where the septic myocarditis was there, and the LV was, after putting him on ECMO, the LV is getting distended, and we unloaded the LV with a transapical vent, and he did well after that. And obviously, the management of LV distension, not in our country, which is the very these cost-effective things are not there. So obviously, the Impella and LVAD, costly but act as a bridge and destination, which can be. Obviously, the RV failure has to be excluded. Otherwise, you will put in the problem, the patient will get in the more problem with this. Harlequin, we know there's another problem when we are facing this VA ECMO things, north-south syndrome, your blue upper body hypoxia, your patients are getting right hand and right ear saturation going down on VA ECMO, particularly when this lungs are bad and you are on VA ECMO. Your saturation is 86 and you are giving a good veno-arterial flow. Your pressures are fine, but your saturation is not picking up. So this is very common thing when the patients are coming out of your this myocardial dysfunction and your lungs are getting wet. This type of thing we can see. So what we do, we go for a triple cannulation strategy. We took a oxygenated blood through his right internal jugular vein to perfuse the jugulars and the base of the heart, which causes this right upper body hypoxia. And this is the way we do. We just divided our output, this arterial output, into two, which one goes to the artery and another goes to the right internal jugular vein, through which the blood supplies to the base of the heart, to the coronaries, to the great vessels, and causes this upper body hypoxia to the good oxygenated blood to the upper body. So obviously, with this situation, if we came out of this thing, winning from the veno-arterial ECMO has to be there. And after this kind of cardiogenic shock patients, according to the ELSO guidelines, hepatic function has to be recovered prior to any attempt to wean patients from ECMO, irrespective of the finding of the cardiac assessment. So hepatic function has to be improved, because we have seen the transaminases in the thousands when these patients are on put on ECMO and we wait for another 2-3 days. Late this transaminases goes down. Patient can be in AKI, but the AKI can be managed after all. But you cannot come down you cannot manage these transaminases if you go for a premature weaning from the VA ECMO. So not necessary to wait for the recovery of the renal function. Just wait for the hepatic function to recover. And if your heart is doing well, then you come out. Don't try to wean at least for 72 hours of VA ECMO, because this is the damaged organs need time to recover, except in some poisoning.
Sir, time is up. Kindly wind up as soon as possible.
Compatible for myocardial recovery, MAP is more than 60, lactate is less than 2, your POTF for lung is fine, and ejection fraction is more than 20, aortic VTI is 12. So then you go for start winning. So this is the for the winning, and put a bridge before winning that will prevent the clot within the circuit when you are doing these things. So obviously the predicting success of your winning is aortic VTI, we measure more than 10. Mitral annulus TDS is more than 6, LVEF 20-25%, and you come down on your flow by 1 liter per minute to a MAP drop less than 40, or CVP rises more than 20. So with this thing, I just last 2 slides. This is a primary recovery of a right this RCA origin, with a 52-year-old male smoker presented with acute inferior MI to another hospital. Primary angioplasty attended, but RCA origin could not be engaged, became hypotensive and shifted to us on NORAD, cold peripheries, severe cardiogenic shock with AKI, bradycardic hypotension. And then we put him on ECMO, and his RV was full, and the TAPC was hardly, it was 9 at that point of time. And TAPC was just 9 at that point of time. So we put him on ECMO and just waited for 3-4 days. As we know, the RV function shock is poorly understood, and RV shock is bad as LV shock. So we put him on femoral percutaneous veno-arterial ECMO, and the flow was achieved 3.28. He had some issues with your limb ischemia, but we managed with the distal perfusion, which is through this PTA, this posterior artery, and he managed this left and right, both are same, this perfusion with this NIRS thing. And day 3, he started improving on his heart, and day 5, we could take out the ECMO, and he was doing fine. So probably this is a primary recovery from the ECMO, no intervention required at that point of time. So obviously this ECMO is spreading awareness about ECMO, DOT to ECMO before DOT to balloon, which is important message from me. Thank you.
Thank you, Dr. Arpan. I also remember a case where we did the primary angioplasty of LAD, patient was doing well, and next day he went into cardiogenic shock. It was a LAD angioplasty after 18 hours, and the patient went to cardiogenic shock. His coronaries were flowing, which rechecked the coronaries. The stent was doing well, and the patient had to be kept on ECMO and IABP for 11 days, and finally he came out. So, like in situations where we are dealing with cardiogenic shock, only ECMO is not going to work, and IABP is a must to have a LV unloading. So, comments from Dr. Kahali, Arindam, Dr. Chakravarti.
So, this was an excellent talk. Very impressive, what you've done with the ECMO volume, and very impressive. you know, um, so when we do ECMO here, I would say 70% of the times patients end up coming to the cath lab for impella placement for venting, which is cost is an issue. So unfortunately, we cannot do that back home. But the transseptal venting, I actually think I've tried talking to my surgeons. I think transseptal venting is a very good option, and it's safe. It's just one transseptal. We put a big cannula, and I so you have and balloon pump. We've done it occasionally if nothing is an option. But our the way we do impella, if impella doesn't work, is not an option, then we go transseptal, and if that's not an option, then we go balloon pump. But I would say 70% of our patients end up requiring LV unloading after after.
Yeah, the experience is same here actually. Experience is same here.
Yeah.
Dr. Tyagi, Dr. Hajra, Dr. Swami, any comments?
Dr. Tarun, I can remember when I was there in your institute, one of the patients during TAVI collapsed, and there was something called ECMO response team, which was fantastic. Within a span of time, the response team came, inserted the ECMO, everything went well, and on ECMO, TAVI was done, and the patient went off home. So Dr. Arpan is also here. How we can have a proper ECMO response team, how to build up a ECMO response team in an institute, your opinion.
Is it my take? Okay, fine.
Yeah, no, I wasn't sure.
No. Actually, speaking, what prevents us from making a team is we are in the private hospital, and the monetary thing, because ECMO here costs straightway 3 lakhs rupees because of the logistics. So that's the problem where it is there. Otherwise, I actually compete with my pantry because if you order a tea and an ECMO, the ECMO will reach first in Medica, and I can assure that. Okay, but only that thing, that monetary thing, which is not there probably with us, and probably this time will come with the awareness that this kind of the few patients where I find the necessity, also Arindam finds the necessity of putting them on ECMO first and or impeller first, then go for a PCI. What we are telling this, just stabilize them for half an hour, then go for PCI. So this DOT to ECMO, DOT to balloon concept has to come. I think it will come. It will take some time. And probably COVID is going to help with that thing.
Yeah.
Any comment?
Dr. Chakravarti, in your hospital now, is it ECMO which comes first or the impeller?
But Anandam, it's so nice to see you. I remember seeing you when you were at Cedars, and it's good to see that you've climbed the ranks very well. Very proud. So in terms of ECMO versus impeller, if a patient for this discussion usually comes up in patients who come in cardiogenic shock with an acute MI, and if a patient is stable enough to come to the cath lab, they end up getting an impeller. If a patient is too unstable to come up to the cath lab, then they go on ECMO in the ER. Our threshold for ECMO has gone up very high because initially we were putting ECMO in a lot of patients and our outcomes were, very. So now if someone is over 75 years of age, our surgeons will almost never put them on ECMO. So 75 is really our cutoff to put someone on ECMO because, ECMO is either a bridge to recovery or a bridge to more definitive therapy. And bridge to more definitive therapy becomes less likely in a patient who's over 75. And, we We do the most heart transplants in the world at our center. Last year we did close to 130 heart transplants. So it's a big center, but even transplant is not an option for those patients. So if they're over 75, they almost never get ECMO. If they're under 75, then if they're stable to come to the cath lab, we put them on Impella first. But if they're too unstable, we call the ECMO team, and the surgeons actually don't are not the first ones to respond. Our cardiothoracic surgery fellows who are trained surgeons doing a fellowship in cardiothoracic surgery, so they will actually come and initiate ECMO on patients, and then the surgeon, the attending surgeons will show up, when they show up. So, but the response time is quick, but I'm sure response time is equally quick there, if not faster, because it's there's more manpower. Yeah.
So thank you so much, Dr. Tarun Chakravarti, Dr. Harpan Chakravarti, all the chairpersons and the expert panel. We have seen wonderful lectures. We have seen live inboxes, excellent discussions throughout the day. And now it's time to conclude. Every good thing comes to an end. So thank you so much for being there. Thanks again. Good night,
Thank
everyone.
you. Thank you.
Good night.